Welcome, everybody. On behalf of Alliant International University, I welcome you to By Yourself But Not Alone, the Strength of Psychology and Primary Care Collaboration. Dr. Alice Davis will be leading us through that. Whether as prescribing and or clinical psychologists or primary care providers, you've all encountered patient concerns or questions that cross over into another discipline. How can we know it all? This presentation will provide insight and strategies to effectively manage patients who require care across the healthcare spectrum. Health assessment, differential diagnosis, and best strategies for communication and collaboration between psychology and primary care will be discussed. Dr. Davis is a certified nurse practitioner who has cared for patients as an independent practitioner and prescriber across the lifespan in rural primary care and urban acute care settings for over 30 years. Dr. Davis has developed and implemented graduate nursing programs, master's and doctoral, in acute care and primary care. Dr. Davis is currently the graduate program coordinator at New Mexico Highlands University, where she's responsible for program implementation while also teaching graduate nurse practitioner courses. Dr. Davis has over 50 publications in journals and textbooks in neuroscience, trauma, and critical care nursing. Dr. Davis has also served on national nursing boards, American Association of Critical Care Nurses, and American Association of Neuroscience Nurses, editorial boards and review boards for trauma and critical care nursing journals. She's received funding from the National Institute of Health and various universities and nursing organizations for her work in brain injury and critical care. It is with great pleasure that I introduce you to Dr. Alice Davis.
Well, hi everyone, and thank you so much. Let me kind of give you a little overview of who I am in a less formal note. My aspiration as I went into my freshman year in college was that I wanted to be a psychologist because I could really listen to people and they all kind of gravitated to me with their questions and those kinds of things throughout high school. So when I got into my first year as a psych major, I did okay. But the thing that was going on in my head was that I was going to have to get a PhD and work with rats. And I was 17, and that didn't appeal to me too much because that looked like another 8 years of education. And I kind of was ready to have fun. Many of the mates that I had, like in my dorm room, my dorm hallway, were in nursing. And I thought, that's perfect. I can get a job. I can get a car. I can have my own apartment. I can do whatever I want. I'll be free and I'll have a successful career. I do have a PhD. However, it's in nursing. And ironically, I have a postdoc in neuroscience and I worked with rats. So all the things that I kind of didn't think about back in when I was 17 that I kind of put off, I actually accomplished much later in my career. The BC stands for board certified. And you all know as credentialed professionals that, you have to go through lots of hoops. So the GNP is that I'm a geriatric nurse practitioner. The ACNP is that I am an acute care nurse practitioner. And finally, I'm an FNP, which just means that was my last certification. And it's a long story, but I just kept going, probably because I'm a second child. So let me talk then a little bit about the title, By Yourself But Not Alone. I guess some of the biggest fears and anxiety for me when I was either a new nurse or a new nurse practitioner was that, oh my gosh, now I'm real and I'm supposed to know what I'm doing, but I don't know everything. So for my whole career, I have actually been working with the idea of not being alone and having other people help me. So I just wanted to start out with a statement about interprofessional collaboration, or IPCP, as it's known. Collaborative practice in healthcare occurs when multiple healthcare workers from different professional backgrounds provide comprehensive services by working with patients, their families, careers, and communities to deliver the highest quality of care. And that's really from the World Health Organization. And I think that we all, in theory, believe that. But I don't know that in practice we can do it, or that it's that it's something that we want to do. So I want to just give you a little bit of my timeline from silo to collaboration. When I got out of my undergraduate program, I ended up in the Army Nurse Corps, and that was in 1979. So I was a real hardcore trauma nurse, and my mantra was that I save lives. And that worked out really well, because in that kind of environment, you need that attitude, you need the confidence. Then I went on in 1983, I went to a graduate nursing program in neuroscience. Interestingly enough, the faculty member who was in charge of this particular program made me go to a rehabilitation unit for clinical experience. Now, as a critical care nurse, I was pretty self-confident. And as a new nurse, I was a little bit arrogant at the same time. And so this idea of going to rehab didn't really mix well with my critical care trauma background. And I told her that. And she said, well, that's fine. If you don't want to go, then I don't think you need to be in this program. So of course I went. And that started my understanding of interprofessional collaboration. It was such an imprimatur in my life that I actually, as part of one of my assignments in the graduate program, wrote an article that got published and was called The Role of Clinical Nurse Specialist in Rehabilitation. It described, back then in 1985, the interdisciplinary approach, because for rehab, that's what they do. And that's what I learned. Moving further into my graduate studies and my trauma background and my critical care background, I wrote an article starting rehabilitation in the ICU. And I sent it to Critical Care Nurse, which was a pretty prestigious critical care journal back in 1986. The reviewers' feedback was this was insulting the intelligence of critical care nurses. Kind of like where I started back in 1979, 1983. Hey, I save lives. What's this rehab thing? But actually, before that, the American College of Surgeons had already put out resources for optimal care of the injured patient. And that was in 1976. And it actually described the need to include rehabilitation into trauma care. Okay, again, I'm in my silo. 1990, I am in an acute trauma unit as a clinical nurse specialist. I'm talking to the nurses about integrating physical therapy principles. And I was working with the patient and the nurse from the rehab principles that I had learned in my graduate program. But I was found guilty of usurping the role of the physical therapist, because what I didn't know that day was that the physical therapist was outside of the patient's room listening to my conversation. That actually started a big problem in that unit. But we resolved it and actually formed a team. We actually formed a rehab team in that trauma unit that consisted of physical therapists, occupational therapists, the nurses, and me. And so it all went well. In 2004, I was an acute care nurse on a trauma team. And that's where I really started working on that shared responsibility. You know what? I'm really not alone here. I really can access my colleagues. And that is really when the silo started to break into more collaboration. In 2010, of course, the Institute of Medicine released The Future of Nursing, Leading Change and Advancing Health. That supported that idea of interdisciplinary or multidisciplinary or interprofessional collaboration. And it focused on leadership, developing programs to harness our ability to change things, and also the interdisciplinary collaboration idea. In 2013, the University of Hawaii at Hilo College of Pharmacy had an MSCP program that they had started, and I needed a pathophysiology course that they had, and they needed some clinical courses that I would be able to do. And so what we did was we swapped out and we collaborated. And this is how I ended up with teaching at MSCP in the academic world. And I love it. And I'm so excited to be a colleague. But the other part of that experience back in 2013 opened the door for clinical preceptors for MSCP MSCP students. So at that time, I was actually a primary provider in a very rural town in Hawaii. I precepted some of the students that were from this MSCP program at UH-Hilo. The best experience for me and my patients was to have this student who was a PsyD come in and collaborate with me. Knew his schedule. And so every week we would make sure that the patients that were on my worry list that I had difficulty with, like, because I'm not behavioral health. So I made sure that those patients were going to be seen the day that he was there. And then what we did was I introduced them to him and he spent some time with them, or I started and I handed them over to my student. I would say without a doubt that collaborative practice between he and I made a very big difference in at least half of the patients that we saw together. One particular 24-year-old who I was just struggling with, he was in and out of rehab. He was an alcoholic. He was a drug abuser. I just couldn't get the story out of him. I just didn't know where to go with him. My PsyD student went in there. He had seen him maybe 2 times and ended up finding out his entire abusive history as a child and all of the things that went along with that and led him to his lifestyle of addiction and self-medication. We changed that young man's life, but I could not have done that without that student who was learning to prescribe, but was a licensed psychologist. I want to put that out there because it was such a powerful experience for me. And I think for also the student. And now 2020 MSCP, I started working at Alliant as a faculty member. I teach the pathophysiology and physical assessment course. It's been a lot of fun with the students, and I learned so much from them. And what we do in that course is that I bring in a lot of case studies of real people. And what's really powerful about that is that they help me see what I don't see in that patient, and help me, maybe diagnose their behavioral health problems, give me some tips. They know that they're doing that because we talk about it as a collaborative experience. And then on the other hand, they get to see some of the physical medicine strategies that I use to diagnose and to manage healthcare, primary care problems, hypertension, diabetes, and those kinds of things. Right now, I am actually teaching in New Mexico Highlands University. I teach primary care, and I also am the coordinator for the graduate program. I wanted to share that because I started out in a silo, and I didn't want to do any of that. I just wanted to save lives. I wanted to just do whatever I did well, but I could manage without others. And over the years, I've learned and I've shared with others the need for collaboration and reaching out. So I kind of have a Pollyanna mindset. I think that interprofessional collaboration improves care. I think it's really an amazing way to get started. For any of you who remember Pollyanna, it focuses on the positive aspects of life, acknowledging negative events, but choosing to focus on the positive and being optimistic and finding good in everything. And that's kind of how I approach life. And I think that that's how I approach my interprofessional collaboration. So I guess what I'm saying is that I would like to collaborate with everyone and hope that everyone would collaborate with me. And who endorses this model? The National Academy of Medicine, who formerly was the Institute of Medicine, World Health Organization. University health science programs are starting to really tap into this, especially for us in nursing. We have a criteria that we have to address in our accreditation that looks at how we are doing, not only talking about interprofessional collaboration, but actually doing it. So I have to find experiences for my students that help them understand and learn and participate in this interprofessional collaboration. Why is it important for patient care? Well, we can involve as many healthcare providers as we can. What's wrong with that? What's wrong with getting other people's knowledge, tapping their knowledge? It improves communication among disciplines, and it also is a primary avenue for sharing information. Let me just say that looking at a Pollyanna mindset, I am real. I do have a reality base. And a couple of years ago, I had a patient who she was struggling with some issues in her life, and I was trying to help her in my own primary care, critical care mindset to maybe seek some counseling and talk things over with someone. She didn't really like that recommendation too much because she was fine. And so over a year passed since I saw her. When she came in to see me, she told me that she had a urinary tract infection. I investigated it, got the history of the present illness and all of that. And she said it started for her in September. And she said she got treated at an urgent care for it, but it never really went away. And so she went back to the urgent care a couple of weeks later, and she got another antibiotic for the urinary tract infection that she was having, and it still didn't go away. And so by the beginning of November, she decided that she would go to some naturopathic provider and see what was going on there. And so then the naturopath prescribed her some medications, minerals, and whatever for her urinary tract infection. But now it's December and she still has the urinary tract infection. So I started to ask her some other questions like, do you have some weight loss? Do you have any abdominal pain? Do you have any pain in your flank, in your kidneys? Just kind of doing a workup with her. And several of her answers were yes. And my immediate response was that she has bladder cancer. I went out of the room and I said, just give me a minute. And now remember, I'm in rural Hawaii. There is one GU doctor on my side of town. To go to the other side of the island is 2 hours. So I call my only lead for somebody that would treat bladder cancer. And the physician was a little short with me. It's part of the who does what structure and all that. She finally listened to me and I said, my whole objective here is she needs your help. But what can I do to help you get her ready so that when she does see you, you will have a clear path for diagnosis? So what happened in that collaboration was that I was able to get that patient, number one, diagnosed, number two, an appointment that was a week away, and number three, have her prepped and ready for that specialty appointment. And it turned out that the patient did have bladder cancer and she was treated successfully. And that was the bottom line. That's just one story out of probably many, but we can all be involved. We can improve our communication among our disciplines. We can ask each other questions. We can get my side prepped for you, your side prepped for me. And it's just a primary avenue for sharing information. And the other thing that I think is important is that when we're doing collaboration, we also integrate the social determinants of health because we have to think about how that works. One of the things that I found out when I'm teaching psychology students is they're very quiet and they don't ask me a lot of questions. So I have to use different strategies to get them involved. And that is one reason why I started using the case studies that were actually patients that they could really engage with. So interpersonal team approach, that's where we want to go. And I put a list of who we might actually access from your perspective, from my perspective. I'm primary care. You may come from a psych background or some other medical specialty. So when I say primary care, you can expand that to medical care as well, right? There's rehab, and I see PTs and OTs and speech language pathology therapists and audiologists, social workers, family networks. We can't really forget that family, the dietitians, the dentists, pain management. How are we going to manage pain without those opioid prescriptions? It has to be an interprofessional collaborative approach to help those patients manage their chronic pain. A chiropractor, an acupuncturist, a pharmacist. And I'll tell you one thing, sometimes being alone in a primary care practice in rural Hawaii was really, really intimidating. Well, one of my biggest helplines is the pharmacist. I have no shame. I have to say that I have no shame. I will call the pharmacist. And when you're in a rural environment, many times you already know the pharmacist. The pharmacist knows you because of your prescribing practices and how you prescribe those kinds of things. But I'm shameless because I would always call my pharmacist if I have a question. The other thing is the information that you get from this interdisciplinary team is that patients don't always tell you the whole story. And particularly older patients, like they don't want to tell you that they fell. They don't want to stop driving. And if they would say anything about dizzy or they fell, everything would be cut off for them and they would lose their independence. I'm not saying that they lied pathologically, but they don't tell all the whole story. So a lot of times what's important is that I can get information from the psychologist or the social worker, and they can get information from me. I can call the pharmacist and say, hey, what else is on their drug list that they haven't told me? And that's a very powerful relationship between you and the pharmacist. And so again, I'm shameless. I will call a pharmacist on a heartbeat, on a whim, just to make sure that number one, I made the right choice in prescribing a drug. Number two, they didn't find anything that was detrimental based on the drug list that they're on that I may not have total access to. So these are the kinds of things that I think are important in that collaborative relationship. And of course, the biggest person that you want to collaborate with is the patient. And that's where you can really hopefully get the whole story and unfold it in a way that is comfortable and non-threatening to the patient. And then, of course, we can't forget spiritual advisors. One of the things that I'm really learning about, we have all the Hawaiian spiritual, cultural things that I deal with, but I'm also very, very tuned into now looking at the Navajo and the people and their religious or spiritual advisors in Indian health services areas. So we have to open that up a lot more when we think about our diverse population wherever we are. This interprofessional team approach is about performance, it's about knowledge, and it's about attitudes. It's a patient care team, and they flow back and forth. And we need leadership, we need communication, we need situation monitoring, and we need mutual support. Those are the skills that we bring to this interprofessional team approach. Let's think about some barriers and successes. I've already kind of told you about some of my personal barriers, especially when I was trying to break through in the critical care world with rehabilitation. But I think that now we wouldn't even think about not introducing rehab principles in the trauma ICU these days. To me, the barriers are our hierarchical structure. We have referral systems. Who's going to pay? Payment systems. Who's going to do this? Who's going to do that? Can we actually do collaborative practice? And who's going to pay for it? How do we refer? So those are kind of some nitty-gritty things that we have to work out. I don't know how many challenges you face in your practices, but in my practice, the difference between what Medicare pays without an Advantage program and what Medicaid pays in the state of Hawaii is absolutely totally different. Medicaid patients, I can get them on an airplane to Honolulu and get them taken care of by a specialist. My Medicare patients without a health advantage plan, I can't do that. They have to pay for it themselves. When we talk about the social determinants, they're already poor people. They don't have financial or the physical access to healthcare. And so that's, to me, a huge barrier. If we can do some other strategies like telehealth or having the psychologist come in for a day into your practice, or a primary care kind of coming in, then that might be worthwhile. Lack of training, that's a big thing because for the most part, we've stayed in our silos. I didn't have any interaction with any psychologist or any psychologist students when I was an undergrad, or even as I went through my nurse practitioner programs, even though we're supposed to be doing interprofessional curriculum. So anyway, there's the curriculum gaps. The other thing is that I think sometimes it's really unclear what do other professions contribute. So what am I going to use the dietitian for? What am I going to use the social worker for? How can I involve someone like an acupuncturist? So it's unclear what we do. And that goes back to our lack of training and the curriculum gaps that we have. Next, I think, is poor communication within workspaces. Think about your work environment. Do you interact with your colleagues, maybe at lunchtime, maybe after work a little bit, but you may be collaborating on patients that are within your specialty, but not necessarily outside of that specialty. What about alternate workspaces? Like, if you're by yourself in a practice, you are alone. One of my biggest anxieties was that I was by myself and I all of a sudden had to be in charge and make all the decisions and write the prescriptions. So those alternate workspaces, we're not communicating with other people. Referrals. How do we do referrals? Do we have a formal consulting system or do we do it informally? Can I just call somebody up and say, hey, can you see this person? Probably not. Or do we have no referral systems in place? And then, of course, our EMRs don't communicate. And that's another big issue for all of us in many ways. Successful collaboration. What's that look like? First of all, we're communicating. We have integrated care models and we have shared knowledge. We actually are working together. We have access to information. We are concerned about not only the mental health, but the physical health of a patient, spiritual health. So we have an integrated care model. The other thing I think is really important about successful collaboration is trust and respect. Building relationships and valuing diverse expertise is really important. Sometimes we see that in hallway referrals and warm handoffs. And I just love that. I love that idea that I can go in and I can say to my colleague, hey, I really need your help on this. Can you listen for a few minutes or whatever? And again, sometimes you have those lifelines. I can make one phone call and maybe get an answer or get some support. And I referred to the GU doctor in that rural community. There was some tension between medicine and nurse practitioners and nurses in primary care. And you know that there's tension in your discipline, perhaps. Who generates that tension? Who continues to reinforce that tension? You have to recognize it. And that's why with my GU doctor, she listened to me. And that was important because we got what we needed for the patient in that particular instance. But that doesn't always happen. Okay, so we have shared goals. There's an importance of common objectives for team success. And we have improved patient outcomes. And that's really the bottom line. And that's the one that should be bolded and in red and have exclamation points behind it, because that's really what we want, improve patient outcomes. With successful collaboration, we can reduce costs, we can decrease our errors, and we can develop tools or platforms for collaboration, and then we can endorse leadership structures and models. So I did put a little bit of a case study in there so we can kind of think about who needs to be involved in this. AM is a 56-year-old male who was employed as a construction worker for over 40 years. 10 years ago, he was diagnosed with type 2 diabetes. Since he was diagnosed with diabetes, he made very few lifestyle changes and is now facing the amputation of his right foot due to a persistent open ulceration. He has numbness and severe pain in both feet due to peripheral neuropathy. He's divorced. He lives alone. He has 2 sons who are estranged. He's obese. He's depressed. And he's drinking 40 ounces of beer daily. His last hemoglobin A1C was 9.6. And just from a diagnostic perspective, you want to keep that hemoglobin A1C about 5.7 or lower if you want to be considered not a diabetic. And if you're creeping up to the 6.1 level, you're probably pre-diabetic or need to be treated as a diabetic. So his hemoglobin A1C is pretty high, which means he's really not doing the things he needs to do to self-manage his disease. He has a limited disability income. He's really not eligible at this point for Medicare, because he's only 56. So he does have some disability and he does not have any kind of retirement or pension from his construction work. His medications include metformin, which is for diabetes, and lisinopril for hypertension, and Lipitor for his high cholesterol. We can call him Andy, and that's not his real name, but we'll just call him Andy and see what we want to do with Andy. So I have those social determinants of health listed for us because we need to think about that in every collaboration, every encounter that we have with a patient: healthcare access and quality, neighborhood and built environment, social and community contacts, economic stability, and then education access and quality. So just kind of think about that as you unfold. Let's think about his individual patient factors. What are some of the things by reading that little brief scenario come out? I see diet. I see income level. I see education level. I see maybe cultural underpinnings. I see motivation. I see mental health, like diabetic depression. I see health literacy. So those are some things that I see just by reading that scenario.
I'm seeing things here like depression, education, family history.
So remember, he's got pain and he's got that peripheral neuropathy. And if you have it or you know somebody who has it, it's a bugger and it's difficult to treat because it's neuropathic. And that's a problem. Okay. He's got lots of family history with his estranged sons. He's drinking 40 ounces of beer a day. Andy is not his name, but this is a real patient. And he used to say to me, I'm not an alcoholic. I pace that. I pace that beer all day long. I'm not drinking it all at one time. And I'm like, okay, who do we want to get involved? Well, he's my patient. So we're going to say primary care. And that could be an MD, a DO, a nurse practitioner, a PA. Okay, so somebody is looking over his primary healthcare needs. And in terms of Andy, in the beginning, it was a little rocky as a nurse practitioner getting Andy straightened out. But who else could I get involved there? Well, we could get an endocrinologist. An endocrinologist would help manage his diabetes, maybe change his medications, give him some strategies, do some continuous glucose monitoring strategies. But remember, we have to think about, number one, social determinants of health. Does he have access to that specialist? Number two, does he have the money to be able to obtain, or the health system, can they provide that kind of access to an endocrinologist? But remember, we're going to look at the social worker, and maybe the social worker or someone like the social worker could help us with getting different insurance, getting him into a state Medicare program so that he would have access to more specialists and maybe even access in terms of travel or getting to these appointments. The dietitian is actually a very, very key player in here because we need to start to educate Andy on what's a good diet for him and his diabetes. Psychologists are going to be paramount with the depression and also pain management. There's a lot of depression, even in diabetes, as you know. They have like a chronic diabetic depression. Getting a psychologist involved or some counseling is really, really important. I did get Andy to finally agree to see someone. And I think that was great because he could tell his stories, somebody objective listening to him without me just like blathering, in his head all the time. But I have to tell you that Andy would come to me often. He would make appointments often because he did have that idea of being alone, being lonely, and needing to have someone reach out to him, and he needed to reach out to someone. Pain management specialists, again, the peripheral neuropathy deserves pain management attention. We can give a lot of medications like gabapentin or something like that. But are we really addressing the need? Does he have the right shoes to manage his feet? And that is where the wound care specialist nurse can come in, and a podiatrist. Andy was with a podiatrist. He had special shoes. So we did a lot of work and reached out to a number of our rural colleagues because we were all concerned about getting him into a safe environment. We all worked pretty well together and talked to each other, at least by referral notes, not necessarily by phone call because, you're busy, but read the referral notes. Or if you feel comfortable, pick up the phone and say, hey, what's going on with Andy? Is there anybody else that's not on this team that you would think would be an important member of the team?
I'm seeing things like a pain management support group,
Yep.
group therapy to validate the experience, wellness coach, friend,
Good.
home health aide.
This is great. These are great ideas. And so wherever you can access care for them and through whom, some of those would come through referrals from primary care. Some of them would come through referrals from a psychologist. The social worker can also pick up some of that work. The group therapy is great. And I think that's a really important piece of helping Andy. One thing that's not mentioned here is the surgeon. Okay, the surgeon who wants to take off his foot or his toes. And that is very valid. Okay, in Hawaii, some of our diabetics say, hey, my grandma had no foot. My grandma had no legs. That's where I'm going. I'm not worried about it. Okay, so this is Andy. He's 56 years old and he's facing losing his foot or at least a couple toes. And you know what? That's in his cultural norm because grandma had it, uncle had it. So these are the kinds of things that we need to think about in terms of kind of delving down into some of that cultural background and that it's going to happen to me sooner or later attitude. I see that as something that's very collaborative in terms of the psychologist and the primary care person. Even pain management. I think we got that. I think Andy is going to get great care based on our idea of who we can get involved and who can we collaborate with while we are working on finding the social determinants of health solutions. He has no money. His literacy is limited. He doesn't have good healthcare access, so we need to get him better insurance. He lives in a little shack down a dirt road with feral pigs in his backyard. And so this is the way sometimes our rural patients live. And we have to reach out to other sources to help them. All right. So if you can Google it on PCN lifestyle clinics, I kind of like this because it's actually something from the UK, but it's something I think that we need to think about as maybe a strategy. They don't want to like prescribe a model, but we can draw on a program run by this kind of spa. Lifestyle medicine integration helps address the needs of people living with chronic conditions. So some of the things that you mentioned, your weekly group session, like 6 to 10 people. The group could be run by a psychologist, a social worker, some kind of a counselor, a nurse practitioner, a nurse, a dietitian, depending upon what it is. There's a health and well-being coach. And I also like this idea of a health and well-being coach, getting people pumped up to take care of themselves, and a psychiatrist. So that was the group in this lifestyle clinic that they run. And the 4 aspects of lifestyle that are covered are health compromising individual challenges, influence of community behavior and vice versa, food and nutrition, and physical activity for health and well-being. And I think that if I had to prescribe something for Andy, this is kind of where I would want to go. You know, what are his individual challenges? What is compromising his quality of life or his ability to be better, have better health outcomes? What is the influence of community and how can we get community involved with him? And that's some of the things that you had talked about in terms of group. He's alone. His sons don't talk to him. Food and nutrition. Does he have the money to buy it? And what are we going to do with that, the 40 ounce of beer that he's drinking? And oh, by the way, over the year that Andy was coming to see me, we got him down to 1 40 ouncer a day. He was drinking 4 40 ounces. So he was down to 1. And I was really, really proud of him. And his hemoglobin A1C dropped to about 6. And his pain and neuropathy was taken care of. And he was really actually able to do some more physical activity. And he worked on his house to get it better. And he was feeling really good about himself. A checklist for collaboration. We need leadership. We need buy-in. We need implementation strategies from silo to collaboration. We need pathways and processes. We need that IPC education. We need to bring that into the curriculum for our psychology students, for our nursing students, for every student. We need shared knowledge of roles, multidisciplinary exposure. academic and practice exposure. And like I said, I loved being in that rehab center as a master's student, and I loved having my prescribing psychologist student in my practice once a week. We need formal versus informal references. We need to diagnose and share those diagnoses. We need clinical notes that we share. Medication review, I can't tell you how important that is. Reconciliation, are they still taking these medications? And you know what worked? What antidepressants worked? What didn't work? Those are important things that I need from a psychologist. Or I don't know what has already worked. And I can prescribe, but I don't know. I need that background. Warm handoffs if possible, interprofessional precepting, as I described before, and certainly shared databases and technology would be awesome.
Any thoughts for students trying to find a practicum site, but they keep being turned away? Anything that will convince a nursing or medical physician to take the student?
Okay. So I don't know where you're coming from. If it's an academic environment, obviously, we have challenges there. Believe me, even in nursing, trying to precept nurse practitioners. So practice partnerships are what you need to kind of get started with. And again, this is a collaborative moment. What are other people doing to get those sites? Everybody's busy. Nobody wants to work. And my Pollyanna view of the world is when I was precepting students, they helped me. They didn't drag me down. They were in there with patients getting histories and physicals and doing the work. That's important. You need to put a strategy together that this is what our students can do to help you, not to drag you down. What can they do to help you? Sometimes the bigger health systems like Optum or systems in your neighborhood, like hospital systems that have other clinics, those are things that you need to target. Because I deal with it every day, trying to get sites for my students.
Is there any type of internship that would offer this benefit of interprofessional teamwork, or is it something I should just integrate into my personal work philosophy?
I think that you need to integrate it into your personal work philosophy. That's number one, because attitude, remember, is everything. I don't know what academic setting you're in, but is there a way to do an elective that you could call a clinical elective of some sort? This is what we need to start thinking about in academic environments. We need to have this set up formally so students can do maybe a 3-credit clinical internship with a primary care person. And then we formalize it, and then we get our memorandums of agreement, and then we get our practice partnerships, and we have our processes set up. You see what I'm saying? So to the student, I would go back to your academic advisor and say, how can I do something like this? And then the other thing, of course, is always insurance for liability for the student being somewhere. So that's always something, but that's outlined in an MOU between the university and the practice. You could start with your own PCP. Just say, hey, is there a way that I can kind of come in and work with you and get the MOU and, maybe start there. And maybe you're going to do it on your own time, but maybe your university would support you to do a directed study in clinical practice.
We don't have clinical coordinators for MSCP programs, so it's each student who finds a site where they live.
Some people or some academic institutions say to the students, hey, well, it's your burden. You have to find something. And other places actually lift that burden. We just started our program 2 years ago in northern New Mexico. I'm telling you, there's nobody out there. It's rural. And we have over 25 MOUs now. And that's because we work on them. Again, the student might come in with an idea. So if you have an idea as a student, then that's great. And then you need to you need to have your faculty help you cultivate that. So if there's not a clinical placement coordinator, then somebody in that institution needs to be responsible for that. That's my advice to faculty. To students, I would say start looking around and see who might be willing. And again, like I said, the lone people like me. Oh my gosh, it was so nice to have this psychologist come in once a week for a semester because I gained more information surely from him than he gained from me. So maybe target those people who are alone out there and say, I would like to listen to you, and maybe you can listen to me. But the only thing is, you have to have some kind of operational memorandum of agreement if you're a student going into that kind of environment.
If I may just chime in for a moment, because this question obviously pertained to MSCP programs, so it was a bit of a loaded question. I know a lot of students are looking for practicums. I think one thing that students have to be realistic about in MSCP programs is that all MSCP programs teach students from all across the country, right?
Right.
It really is not possible for one program to develop internships in the States, wherever students may be residing. However, of course, the program director is always the point person for a student to contact, and any student who wants to think seriously about starting and finding a place should contact the program director for that particular MSCP program, so that those efforts can begin.
You're absolutely right. And thank you for bringing in the fact that you are across the country. And, there's lots of other issues about crossing states and education across states. And there's an organization called SARA, and that organization actually helps you make alliances with programs and higher education in the state. California is actually one of the most restrictive states to bring students from one state into California. When I'm looking for SARA placement, I don't even think about California because it's so cumbersome. But you might be able to, if you're not in California, go to some other places. That's a challenge, and we need leadership to make that happen. So in my Pollyanna mindset, it's possible, but how it's possible is not just call somebody up and get in there. So it's going to take some strategies. So thank you for your input there. I appreciate that, George.
We don't have any more open questions, but there were some wonderful responses. We are creating an organized collaboration in my community. I did an APA accredited internship in an integrated primary care setting with Providence in Oregon last year. To the PhD student, I did my internship and postdoc at Cambridge Health Alliance. Other sites are Cherokee Health Systems, and other places are developing primary care behavioral health internships or rotation. Join a listserv or professional organization. It's definitely a challenge. Took me 2.5 years to find a site for RXP. Other folks are saying thank you for a great presentation.
Well, it's my pleasure to be here. And like I said, I'm humbled because I'm so grateful that I've had the opportunity to have so many great collaborative experiences and to share some of that with you. Remember, you're not alone. There's somebody that you can reach out to. You might not get $1 million for the answer, but there's somebody out there that can help you, and reach out to them, whether it's a nurse practitioner or endocrinologist or something, and start making those relationships. And only we can do that. We're the only ones who can really build those bridges with other people. It's our kuleana. Kuleana is the Hawaiian word for responsibility. So it's our kuleana to reach out and start the process. So thank you so much for listening.
Thank you for joining us. We really appreciate your expertise in this very important area. Just a final thought as we close this wonderful presentation. The training provided in the MSCP programs prepares students so well for becoming embedded in primary care settings. So that is something to think about if you have interest in practicing in such a way in your professional career. Obtaining an MSCP would be a great way to prepare yourself to be able to practice in such settings. The other thought that I have is when you approach physicians about working with them more collaboratively and about possibly becoming embedded in a primary care setting, if you can show background in medicine, in understanding medical illness, in understanding the interface interface between mental health and physical health, and help the physician understand that your being there will support the way they provide, medical care to their patients. I think that's what they're looking for when they're considering whether or not to accept a mental health practitioner to, have a more collaborative practice model.
I'm very proud as a nurse practitioner to be part of the team because Alliant's program is interprofessional that provides such a broad overview of so many different things from so many disciplines. I think it's a great program. I'm proud to be part of it.
Thank you for saying that, Dr. Davis. Yes, that's one of the things we are proud is that we actually have a representative from all the major prescribing professions, like yourself, a nurse practitioner. We have a psychiatrist. We have prescribing pharmacists. We have prescribing psychologists. So I think students do get the exposure to the variety of approaches that these prescribing professionals have.
I just have one other funny story. So I used to get my optometrist to come and do all the eye signs and use the ophthalmoscope with my nurse practitioner students when I was teaching in Hawaii. I was also practicing at the same time. And he called me one day. This optometrist called me and he said, Alice, I have a deal for you. I would love for you to do primary care in my eye clinic with my patients that I see for eye exams. Because what's he seeing? He's seeing hypertension. He's seeing diabetes in their eyes. And so he's thinking, oh, how can I expand my practice to include a more collaborative approach and better quality outcomes for my patients? So I just thought that was a very unique perspective. I thanked him profusely for the offer, but at that point in my life, I was so overloaded that I couldn't really make the transition. But see, there's so many possibilities. And he's thinking about, wow, diabetes, these people aren't getting treated for their diabetes. They're not getting treated for their hypertension. And I'm seeing that. So.
Alrighty. Well, if there's nothing else to add, thank you so much, Dr. Alice. Thank you all.